started on the questions that we've had sent in, and if you have any other questions for us, please pop them in the chat and I'll keep an eye in there as well. Right, question number 1. Patient on clinical trial for rituximab, am I pronouncing that correctly, to treat PBC fatigue, found that it was really helpful. Is that a medication that can be now available on the NHS?
Well, that's very interesting to hear. So the rituximab trial was one that we did a few years ago. And it was based on some work that Mark Swain had done. So Mark, who many people will know, is a great friend of PBC and the PBC Foundation, very good PBC doctor in Canada, is if you ever want to, I don't know if you're going to be on from Canada, all you need to do is call it the 51st state and they get really wound up. It's quite entertaining, actually. I shouldn't say that, but Mark had did a small study of rituximab. Rituximab is a biological, so that's a particular type of drug based on antibodies, and many people will be very familiar with the sort of revolution in inflammatory bowel disease and rheumatoid arthritis and psoriasis, where these drugs are really effective at controlling these diseases. So they've been one of the big, transforming things in disease in the last sort of 20 years. There's a whole family of them. And there's always been an interesting question is, why didn't we use them in liver disease? Because we use them in all manner of other types of autoimmune diseases. I've been asked that question by patients in clinic. We heard so much about this. My sister's on, anti-TNF, which is a standard drug for rheumatoid. Why don't you use them? It's a good question. So Mark had given rituximab. Rituximab gets rid of what are called the B cells. These are the antibody-producing cells in the body. And you think that, why would that be important in PBC? Well, we know that overactivity of the antibody-producing cells is part of PBC. So you get the AMA that they come from those cells, and also there's a thing called IgM, which is one of the antibody types, which is always high in PBC, and that's one of the tests that we use. So there's kind of something going on with the antibodies. The other thing that these cells do is that they boost the immune response. So they sit there producing lots of chemicals which boost other cells. So they're a bit like a turbocharger for the immune response. And so there's a kind of specific reason why it would work, which is getting rid of the antibody producing cells. There's kind of a more general way it might work, which was in terms of damping down this turbocharging effect. So Mark had given rituximab to some PBC patients. They all tolerated it very well and showed some real benefit in terms of fatigue. Okay. So we picked up on this and thought maybe that, many people will know, having spoken to, heard me talk on occasions, and will know that fatigue is a big focus of what we do, and in particular finding treatments for it. So we did a trial funded by the Department of Health in the UK, a bit like the OPERA trial, which is ongoing at the moment. So this government support for PBC research, really done by somebody called Laura Griffiths, Laura Jopson now, who a number of people will have met, who's just lovely, and a great PBC doctor still with us in Newcastle. So we did this trial, and like many trials, the answer is unclear at the end of it. So in life, we always want a black or white answer, but anybody who's done clinical trials will know the answers are almost always a shade of grey. So what did we see when we gave rituximab or basically saline to people who had fatigue with PBC? Well, the answer is we saw improvement in fatigue, okay, measurable improvement in fatigue, but we also saw some improvement in fatigue, not as much, but we saw some improvement in the placebo groups, the people getting saline. Now, that's the nature of the beast with these things, because it's not like measuring a hemoglobin or something, which is a hard number. This is how people feel. And, if you think about it, the whole act of being involved in a trial where there's some, a really positive feel about improving things will itself help people feel better. So it's the nature of the beast. And that's one of the difficulties. Two other things happened with it, which is really interesting. So the first is literally everybody who got rituximab at the end of the study had normal liver blood tests. Everybody. Okay. Now, not everybody had normal blood tests at the end who had been on placebo, but because fatigue doesn't really affect people with worse liver disease, the blood tests weren't that bad. So statistically, it wasn't different, but in absolute terms, everybody normalized. And it actually answers a question that's never been answered before, and it's in there in the paper, which is in a journal called Hepatology, which is quite a good journal. What happens if you turn off the immune response in people with early PBC? It's never been done. Trials have always, of biologicals, have looked at people getting who've sort of failed to respond to urso, which is the standard, second line treatment approach. It's the only time anybody's given biologicals to people actually who hadn't failed urso therapy. And when you do that, everybody has normal liver blood tests, which I find very interesting. The other thing which is in the paper is one of the things that we know about people with fatigue with PBC is that the way your muscles use energy is abnormal. So people tend to run out of energy faster. So again, when we talk about fatigue, we don't use the word fatigue. Actually, we use the term brain fog, and we use the term muscle batteries running down. And the reason for that is that actually they're two quite distinct forms of fatigue. People can get one or the other or both or neither, but they're quite distinctive. The reason we call it brain fog or batteries running down is because they're the words that people use. And so if I say the word fatigue, it means different things to different people, but we use those words because they kind of mean something to people. So we found that when you get rituximab, so we know that PBC patients produce too much acid in their muscle. So we again did this a few years ago. There may be some people on the call who were involved in that, where we asked you to go into and then the person who was in the rituximab trial will remember this because we had an element of that in the study. So we looked at all of this muscle abnormality. So people basically act as if they're running out of power very quickly and they produce too much acid. So like the metaphorical sprinter running down the track, doing 100 meters, by the time they've done 100 meters, they've run out of energy and they've got a lot of acid in their muscles. And that's why you feel really tired. And PBC patients naturally do that as part of the disease. And we measure a thing called anaerobic threshold, which is where the body gives up trying to produce energy in a balanced form and just basically produces acid. And every time there's a thing about sports people, every time there's a thing about sports people training, they're on a bike with a mask over their face. You'll have seen it loads and loads of times. So that's measuring the anaerobic threshold. Okay, so that's measuring basically how well your body uses energy. And anaerobic threshold is really, really low in PBC patients. So you're behaving like you're very unfit in lay people's terms, but you're unfit because of the disease process. That's what the disease is doing. Mm-hmm. What rituximab did was normalize that. So it turned that off. Now, does that make any sense given the role of antibodies? Well, the answer is the chemicals that are boosted by the B cells actually drive down on how your body produces energy. So the bottom line of all of that is that it was a trial that showed some clear benefits, but they were grey rather than black and white, which means it's not a standard thing to do. If we were to do the trial again today, we would do it differently. And the reason is we didn't at that point have the distinction between brain fog and muscles running down, and we ran the two together. And we felt that, and I'd be very interested in the person who was in the trial and felt it benefited. Our feeling was that this worked more for muscle power and batteries running down than for brain fog. I'm prepared to be contradicted about that. And we probably mixed together different groups of people, and we should probably have separated them out. So how you design these trials is actually really important because you can end up making it grayer. So what does that mean in practice? So in answer to the question, rituximab is widely available on the NHS. It's a relatively cheap treatment. it is actually very safe. So, we're always cautious about biologicals, but of all the biological drugs, it's by some distance the safest. It's used routinely by lots and lots of people in kidney disease and lung disease and things like that.
Mm-hmm.
So these are potent medicines, but this is a very safe one. And so it's a thing to discuss. We use it a fair amount in liver disease. We mainly use it in autoimmune hepatitis, where it's actually a really effective treatment. We have used it in PBC. It's one to discuss with your consultant. And if anybody was in that trial, and it would be useful to what we call unblind it, which is to find out actually whether you had the rituximab or the placebo, we can tell you that. So you can get in touch with us separately. And if that's useful information for if you felt better, you felt better, but that will be useful information for your doctor. And I think evidence that was the case is quite powerful. So the answer is, would I use it? Yes. In the right person, in the right situation. And I think if you're in a trial of rituximab and the rituximab showed benefit and you were on the active drug, then I think that's a very good reason to do it. It's the most valuable reason to do it. So if that's useful, I can find out about whether you were on the active drug or not. But it'll take me a little while to dig it out, but it's easy to tell. So the answer is, it's one of those things which is a bit of a curate's egg, clear benefits. We probably didn't do the trial in a way that would have been the best way of doing it. There were clear benefits with the drug. That fits with what people said, but we saw a bit of a placebo effect. But don't lose sight of the fact, if you do completely turn off the immune response in early PBC, you completely normalize the disease. And I just think that's useful for us to remember.
Yeah. I'll be able to hook you up with the person who had sent that question in, so I'll do that offline.
Yes, of course.
And we'll get that for you. So what we're saying in principle then is, I know it's slightly different because the patient we were discussing there had been on the trial.
Yeah.
But could any of us raise that with our doctors now and say we'd be interested in trying it for our fatigue?
It's not licensed for that, okay? But then rifampicin isn't licensed to manage itch, or bezafibrate isn't licensed for PBC. So when we say it's not licensed, this is there are two stages by which a drug is approved, well, three, by which the drug is approved. The first is that it is approved for any use, okay? So rifampicin is approved as an antibiotic, okay? That's how it's used. I want to come back to something about rifampicin in a second. So not to do with this. So that's its use. It's a licensed drug, which means that any doctor can prescribe it, okay? It is not, however, what we call labelled for PBC. So when you look at the patient's information leaflet, it doesn't mention PBC, okay? So we are using it what's called off-label, all right? So it is licensed, it's a licensed and approved medicine, but we are using it for a different reason to the one that it was approved for, right? Now, that is perfectly acceptable. However, it has to be something that you are comfortable with, as is your doctor, okay? And it's one where it is in your interests and you understand it being in your interest to do that. And what that's normally interpreted as is there isn't another treatment that is licensed for that you haven't had, right? So rifampicin, we would never use rifampicin for somebody who's not tried Questran. People often say, why do we try Questran when it's so horrible? Well, it's a bit of a choreography, if you like. So, I mean, there are people who do well with it, and it's a very safe drug. So there are reasons to use it, but Questran. But if it doesn't work, and I want to use something like rifampicin, I have shown that the licensed treatment hasn't worked. Okay, and that means it's legitimate to do this, provided you understand it, are comfortable with it. Now. I mention that to everybody, but it's not a source of concern. It's a totally normal thing. It's never been labelled for PBC because nobody owns it, and it's an old-fashioned drug that's off patent. It's a generic drug. Nobody owns it enough to want to go through the approvals process. So it's not that it's not approved for PBC. Nobody's just ever asked the question. So that's that grey area. And rituximab's actually in that grey area. And then the third one is NICE approval for it. So people will know in the UK about NICE, that determines the cost effectiveness of drugs. Now, there's an element of pragmatism about all of that to do with cost. Now, rifampicin costs about 30p for a month, so nobody will bat an eyelid about us using it in people. It's just insignificant. Rituximab is a treatment that you have 2 doses 2 weeks apart. That's what it is, and that's usually enough for 9 to 12 months, something of that order. And those 2 doses cost about £500. It's really cheap, actually. It's really cheap as a drug, and so it doesn't usually cause cost concerns. So do I think people with fatigue in general should think about it? It's probably going a little bit far. Is somebody really, really struggling with it? It's something to think about. And go and talk about your doctor. And if your doctor wants to get in touch with me, I can explain the whys and wherefores of it and the data. And like all of these things, nobody had any problems at all with it, or has ever had any problems in PBC or in autoimmune hepatitis for that matter, and they're very rare. So it is actually a very safe drug. It's actually a pretty cheap drug. And once you've been through some of the obvious things, it's a reasonable thing to think about. And I'm happy to correspond and communicate with people to give that background to it. It's the difference between, if you go to your GP and ask them, they're going to say not a month of Sundays, right? You come to somebody like us and we'll talk and think about these things, because we talk and think about these things all the time, and other consultants will be kind of somewhere in the middle. But it's something that it's worth thinking about. If you've had it in a trial, okay, and you benefited from it, then clearly there's evidence for you. It is one of the advantages of going into a trial, is that for somebody in the general population, all we know is what happened into the group of people who were in the trial. And so can you extrapolate from those people to the person in front of you? If the person in front of you is in the trial, you know the answer. And that's why unblinding it, as we call it, is very important, because it tells them exactly what you had and if it's worked. I mean, you can use it repeatedly. So if you've been in the trial, can you have it again? Absolutely. I was talking to one of my friends in kidney disease, and she told me that she's got people who've had it 30 or 40 times. When it wears off, they retreat with it, which is very interesting. So
is that an infusion then, rather than a medicine?
Yes, it's an infusion. Yeah, it's about half an hour. It's about half an hour to an hour's infusion, 2 weeks apart for 6 to 9 months. I'm guessing in terms of the impact people feel, that's that's a pretty acceptable thing. I mean, bring a book, bring even a magazine. It's not even book length, is it? We used to use a lot of pamidronate, and many people may remember this, for bone control. So rather than a tidronate where you'd take a tablet and stand up for a couple of hours, pamidronate was an infusion over half an hour that lasted a year. Actually, patients must prefer doing that. That was regarded as a reasonable trade-off. And I think normally you wouldn't go for injections versus tablets, but actually people cope with it. In fact, that's all changing. So it's an infusion, not an injection, through the skin. It's into a vein, but it's no big deal. It's done routinely. What's of course changed, I mean, people were always happy giving injections at home. Insulin, people would always manage their own. And then we moved into giving people heparin. So when people had a thrombus, you'd end up on warfarin, which is at the end of the day rat poison with marketing. Okay, so it is rat poison, and it has its own ups and downs and blood monitoring, things like that. So actually a lot of people had a thrombosis after flying on a plane or something, would elect to do daily injections. I had my knee replaced, and I've got a family history of clotting, and so I had heparin. I gave myself heparin injections for a month, right? And it was no big deal. And actually it's becoming a lot more common to do that. And of course, I have to say, Wegovy and Mounjaro are, of course, injections that have gone mainstream that people are very comfortable doing. So it's changed. There are newer versions of rituximab coming along, okay? And they are not infusion, they are an injecting pen, and you can use them more regularly over a period of time. And there's a trial just finishing. There is a trial just finishing in autoimmune hepatitis using one of the newer generations of this, which looks very interesting. So it's a new generation of all of that. There's a really good question about if rituximab, I hope you don't mind, shows that I read the feed coming through. If rituximab alters B cells.
Wait a minute. That's not allowed. Yeah, okay. I'll let you take that one just because it's talking about rituximab.
So is this, I'm not allowed to answer my own questions? Is this what you're saying?
No, what I'm saying is I don't want you going rogue. Right.
Look, you lost that battle a long time ago. I was going to answer that because it's a really good question. It's directly relevant.
Because it relates to this one,
And I've actually and thank you for the person who raised this. In all the years we've done this, I've never once talked about rituximab. So, I mean, I always say this, but it never astonishes me. I start to talk, we get the chance to work something I haven't talked about before. And obviously, as you can tell, this whole area of this weird interplay between the immune system and how your body produces energy is really interesting. We think is at the heart of fatigue. And the rituximab thing was, I think we did it probably a bit ahead of our time. So if rituximab alters B cells, would there be an increased risk of infection? So that's a really good question, okay? And the answer is nowhere near as much as you think it would, okay? So if you have an anti-TNF, so something like infliximab or etanercept, which are the big original drugs for rheumatoid or for inflammatory bowel disease, you did see an increased risk of things like TB, you know, and some other, and that will be a serious risk with them. This is what we were all worried about with rituximab when we first did the stuff in PBC. Are we going to see problems with the infections? And the answer is absolutely not, none at all. And nor do people giving it for other reasons. So the answer is not as much as you think it does. Remember, there are two sides to your immune response, or three sides. There's the B cells, then there are what's called the T cells, and then there are the inflammatory cells, okay? And actually, B cells are not as important for fighting infection as you think they are. The one thing they are important for is response for vaccinations. So if you if you have rituximab and then get vaccinated, your vaccination will not work, okay? Because vaccines are all through antibody production. And so we had a number of people in settings who didn't seem to respond to the COVID vaccine. Well, that's no response. That's no surprise because you needed the B cells. So the answer is nowhere near as much as you think it's going to. And certainly in the trial, we saw not a single infection at all in anybody. So you think it would, it doesn't.
Brilliant. Thank you for that. We're going to move on to the next question that we sent in. Now, it's interesting because it does touch on fatigue and also on knee replacements, which you've just mentioned, your knee replacement. Patient who's had a total knee replacement, on the whole, recovery has gone well, but has had knee lock twice, as if marked cramp in all muscle groups surrounding the knee. Both times at night, both on their days when their PBC fatigue was significant, like at a 10. Patient has seen a physio, and they both think that PBC fatigue could be implicated in the knee locking instance. Can you say that today for some reason? You know what I mean? The peripheral aspects of PBC. Patient has had a knee X-ray, and the radiographer could see no signs for the lock-in, and they're going to send a report on to the GP. But we just wondered what you were thinking about is that.
Gosh, that's a really interesting question and very personal to me. I had a knee replacement in March last year, and it's extraordinary. I've discovered how many of my patients have had knee replacement because it's become a common topic of discussion, and we compare notes, and it's interesting. So what the description here is that a weird locking when the fatigue is bad. Okay. And I was thinking a lot about this because I think it's a really interesting question. Now, the thing about knees, so hips, the hip, you've got a a sort of socket and your hip, I'm impersonating a hip badly there, it locks in, right? So there is a physical stabilization. So when you're standing upright, the weight of the body kind of locks the hip into the socket. Okay, so gravity locks a hip, right? And we get shoulder dislocations, but you never, short of major car accidents, you never see a hip dislocation. That's because this anatomical lock. If you think about a knee, it's like that. Okay, there is no anatomical lock. And so a knee is stabilized partly by the ligaments around it that footballers are always tearing, and partly and mainly by the muscles. Okay, so the muscles are what you are stabilize, are what's used. Muscles play almost no role in stabilizing your hip, but if you think about it, the only thing that keeps a knee together is slightly the sort of fibrous ligaments, but mainly the knees. Now, I discovered this. You're going to find out about my knee in a way you don't want to. I had knee problems for a long time, then fell off a mountain bike, more stupid than you might imagine. I could control my knee pain and the locking by exercise. Okay, now exercise would make the pain worse, except once I'd finished exercising, the pain would be better. And what I think I was doing was strengthening that muscle, strengthening around the knee. Mm-hmm. Is that I was really working hard on making those muscles stronger. And actually, the reason I ended up having a knee replacement, it's my life story, isn't it? I mean, it's sort of, oh, my mum and dad, my mum said if you go out without a raincoat, you'll get pneumonia. I mean, it's like that, isn't it? Who knew?
We never know where it's going to go. We never know.
Never know where it's going to go. So my knee got really bad during COVID because I couldn't go to the gym anymore. Okay. Now, those of you who know me, I'm towards the stouter end of the spectrum, shall we say. So my knees have had a bit, and I used, ski and, was a front row forward in rugby and all of that. So my knees have taken a lot of pulverizing over the years, and I had really strong, calf muscles and thigh muscles, and that was what kept my knee okay. And when I couldn't go on the machine and kind of, lying press 250 kilos, I lost that strengthening around my knee, and that's when I ended up with lots of problems. It was really fascinating. And then after the knee surgery, and I worked really, really hard, as you will have done, on my exercise and my physio, and my knee is completely free of pain. So what I'm trying to say there is I think that strength and power around the knee muscles is really important for normal functioning of the knee. Mm-hmm. And PBC patients, when we did our work on exercise and muscle function, we showed two things. One is, the first thing in it people tend to forget. So what we showed is that people with PBC fatigue, their muscles would be as strong as anybody else's. There was no difference in the strength. Okay. Mm-hmm. However, there was a real difference in the ability to sustain exercise. So normal people could kind of do something and then it would flatten off. They could they would lose a bit of strength by repeat exercise, but then it would wear off slowly. So actually they could keep going. Whereas the PBC patients just plummeted, literally to the point at which they couldn't move anymore. Okay. I mean, we literally saw that. So we actually did this with hand grip strength and actually saw people literally grind to a halt, that they couldn't do anymore. And if you let them recover, they got back to where they were and they had the same strength they had at the beginning, and then it would decay faster. So what I think, and this is to pass on to your physio, because this is a really interesting challenge for them. I think what happens in PBC muscle is that I think muscle energetics are at the heart of peripheral fatigue. I think you run out of capacity to repeat exercise very quickly, and so then end up in a state of dysfunction. I think what you're describing is basically a loss of the muscle stabilization, because you are grinding to a halt in that form, and that's down to the PBC. We think periods of inactivity make this worse. So not doing very much makes it worse. It's a bit like, training for sport. And obviously those people, coming up to knee replacement are not as sprightly. I know all about this. Are not as sprightly as they were before, and then you kind of laid up for a little bit of time, you do your exercises and things, so you would expect some dropping off of your capacity anyway because of the problems and then the operation, and in the rehabilitation they'll be coming back. But what you're describing is that when the fatigue's worse, this is worse, but that's because the fatigue and this are both caused by an inability to sustain repeat exercise in the muscles. And the answer to that is twofold. The first is, this is precisely why we use coenzyme Q10, because it increases the ability to have exercise capacity. So coenzyme Q10, which we did trials on, a few years ago, it's a vitamin you can buy in supermarkets, 100 milligrams or from Amazon, 100 milligrams a day. It is not the answer to fatigue in PBC, but it takes the edge off fatigue in PBC. But it is particularly valuable for people with prominent muscle problems, because it helps with energy generation using a mitochondrial approach, so aerobic exercise. And it's not expensive at all. Get it from, people tell me Amazon is the cheapest, 100 milligrams a day. I think it's about £10 for a month or something like that. It's not expensive at all. And then the other one is exercise physio. How do you get to be a really good sprinter? You do it by training. Okay, and it's exactly the same for you. So the message for your physio is, yes, I agree with you and your physio. I think this is to do with muscle dysfunction in PBC. It is not to do with absolute strength. It is to do with sustained strength, which would kind of fit, because you need your muscles to be strong all the time to stabilize the joint. And so essentially work to build up all of the muscles crossing your knee is what to do, and they will have the exercises for you. And don't know who obviously don't know the details of your physio, okay? But what I would say is that not all physios are the same. And so you'll have people who specialize in chest physios, people who specialize in, rehab physios after stroke and things like that. But actually you need a sports physio. So this is sports stuff. So you need the sort of physio who is very, very comfortable rehabilitating people after knee ligament injuries to build up those muscles. And if you aren't seeing that sort of physio, then it's really, really not expensive to go and see one for an hour and get some exercises. And it may make a massive difference to you. We can argue until the cows come home about the NHS and access to all of this. But a really good sports physio, it explains what I've just, you explain what I've just said, is that you're at risk of, there's no risk from you doing a lot of exercise. You cannot hurt yourself by exercising and strengthening your muscles. All you can do is benefit, but targeting it around the hamstrings, the quads, those muscles that span across the knee. And I would be, as I'm sure Mo would be, utterly fascinated if you do that, to come back on and tell us what happens with it, okay? Because you've got a very specific situation which it's been made specifically worse, which means where this may specifically benefit it. Absolutely fascinating. I am convinced it's the inability to sustain exercise. So Q10 and exercises for rehabilitating knee ligament injuries, which will be the ones that fundamentally strengthen the muscles around your knee.
Brilliant, thank you. Really interesting discussion today after that, isn't it? I think it crosses over so many things, doesn't it? So brilliant.
Much of what we've done about fatigue comes from the sports science world. We can all learn something from a different world. And one of the things I always say to people is gyms are great for this. And one of the things that the UK does is we have a regulation system for instructors in gyms. And I don't know if that happens in other countries, but certainly in the UK. So the person who's in the gym watching over things will be an accredited instructor for safety reasons, and some of that's around resuscitation, somebody has a heart attack or something like that. But then they have specific modules and skills and certificates in different types of exercise intervention, and they're really well trained. So that means that they are. So when you go and have an assessment in a gym, explain what the issues are, and they will design programs that are fit for you. And it's really good. And for those people who are kind of terrified that it's going to be full of 25-year-olds working on just that muscle there to make it look perfect for Love Island. Apparently that's a TV program. I've never heard of it, but there you go.
I bet you do.
There you go, into Love Island. Who knew? It's not, right? Gyms are full of people just like you. Okay, they're full of absolutely anybody and everybody, and it's one of the refreshing things.
Yeah, I recently started training with a PT in my local gym for that reason, for building up strength in my legs and my arms. And I have never seen such a diverse range of people going into this gym, and it's a pure gym, so it's just a regular chain gym. But the trainer that looks after me looks after specialist clients. So she took details of my condition. She wanted to learn more about PBC. I took her in some leaflets. She has been absolutely brilliant.
On a serious note, actually, I've just thought of something. Should we write a leaflet on muscles, PBC, and physiotherapy?
I would love that, because then if patients can take that to their because that was a bit,
send that out to everybody so that they can give it to their physio. Shall we do that?
Yes, we shall. Actually, I shall write that down.
Your physio, I think, would have been fascinated to hear that discussion, because that would be absolutely right down the street. And we work with exercise physios about all of this stuff. So, but they won't know it. It's really cutting edge stuff. So I think we should write a leaflet about muscles, fatigue, and PBC, what we think's happening, to guide them as to what might be the best approach. And I'm not the right person to design exercise programs, but they are. And I think that between us would be really helpful. So let's do that.
And certainly
we'll put it through. We'll put it through, make it available through the website, and anybody can download it. And, it will be written to be helpful. Okay. This is not criticizing what they do. And I think they'll find it really interesting, actually.
Yeah, no, I was just going to say that the PT that I dealt with, she was certainly open to me bringing in information. She wanted to know a bit more so she could help make sure it was personalized to me. So, and it's made this building up the strength has made a massive difference to me. So
remember that if you're very unfit, the first bit of fitness training works really quickly. And I'm not being rude to anybody here, because it's the illness that makes you unfit, but it is biologically the equivalent of being unfit. But if you're very unfit, a tiny amount of training will make a big difference. And so for that reason, but a lot of people lack the confidence to do it, and the sense that how am I going to be able to do all of this? And so I think the Birmingham people, I mean, this goes into something more general around movement is medicine, and the Birmingham, and I've forgotten her name because I'm very old, but there's a really, really nice academic physio in Birmingham who works
they were at the patient conference last year.
Who was it? What's the name?
Oh, the Felicity and Alice.
Alice, yeah. Okay, Alice.
Yeah.
They've done really, really good stuff. And what they've done is, and really committed in PBC, and what they've done is go into what sort of exercise you should do. So I'm a kind of advocate for exercise, but and I think generally mixed. And there was a comment that went through, I'm going to do it again, about you strengthening your gluteal muscles to stabilize your knee. Absolutely correct. And that's where you need that sort of input, because it isn't always the obvious muscles that's with all of that. So maybe we should actually, I'm actually doing something with Alice about fatigue soon. Let's involve her in that leaflet.
Yeah, and I've asked her about doing one of these sessions as well, so she was up for it. We could get her on with you, and God forbid I was talking about physiotherapy, and when she comes on and does this, please tell her how positive I was about physiotherapists. So just a point as well, that talk that they did for us is on our YouTube channel. If anyone wants to watch it, we've got that recorded from the patient.
They're really good. We should get her and just what I'll write the bit about metabolics and fatigue, and then she can write a bit about what she's done, and then just basically anybody can download it and take it to their physios, and that might be a really clever thing.
I would love that. Yeah, let's do that. Yeah, let's do it. And I would just like, on a final point of going and training, about, I would say that the word I would use to describe myself is I feel so much stronger than I did before. And I think as patients, we're always a bit worried, how much is too much? Do we overdo it? What do we do? But I feel so much.
Can I also say you look really well?
I am. It's interesting listening to you, because after my sessions, I am very tired, but it really makes, I feel like I've invested in it, and it's making me feel better. So I would really and again, there was the difference of the trainer. She really took her time with me. She wanted to know about me and PBC, and so she was brilliant.
And there's a comment from Debbie about specific qualification for personal trainers in long-term health conditions. Absolutely. And at the higher levels, this can be in people with really complex cardiac conditions and things like that. And I think it's a really excellent system. And but basically, I guess the point is they haven't just wandered in and put a uniform on. They are trained, and it makes it very safe. And I think that should give people confidence. These guys know what they're doing.
And most gyms will have a personal trainer who looks after specialized clients as well. So that's worth asking as well. But if we could prepare something that patients could take along, I love the idea of that. So let's do that. Right, I'm going to move on, because we've got through 2 questions so far today, and it's well past half time. I know.
And I want to answer the question about SLA, because I want to answer the question about SLA. And
that is the next one that's on, because that one had been sent in. So that's next on the list. So I'll read it out from the chat, and then we can answer it. So I've been diagnosed with PBC, and I'm responding well to UDCA so far 1 month in. My ALP is falling nicely, ALT is coming down naturally, and bilirubin is normal. Alongside the classic AMA positivity, I also tested positive for anti-SLA. I've heard Professor Jones say that sometimes people can have odd antibodies that don't actually change the prognosis or diagnosis. Could my SLA result be one of those, given the overall pattern is being classed as PBC?
Okay. So I love a good antibody. The classic antibody of PBC is AMA, as people on here know. And then that's 95%. 30% of people have one of the nuclear antibodies, 20 to 30%, and those are 2 different nuclear patterns. Now, you will have heard of the term nuclear antibodies. Those are may have heard of them. They are always associated by doctors with SLE, or less so with autoimmune hepatitis, but you see them in a variety of conditions. So that's a mistake from people. They are one of the less useful autoantibodies because they are present in a number of different conditions. So if you've got somebody with a liver abnormality and an anti-nuclear antibody, it's often autoimmune hepatitis. However, it can also be PBC. And the pattern of staining of the antibodies are quite different in terms of what they do. And so your doctor, if you've got an anti-nuclear antibody, you should ask your doctor what the pattern is. And they should, if they haven't got that information from their lab, they can get it. And so in simple terms, for lupus or for autoimmune hepatitis, it's what's called a diffuse staining pattern. So the nucleus is all stained, whereas with PBC, it's either dots in the nucleus or the rim of the nucleus. So it's easy to distinguish. If you've got one of those nuclear antibodies, it's PBC. If you've got one of those without AMA, it's PBC, and it's really important. So those are the classic PBC antibodies. We then sometimes see autoimmune hepatitis antibodies in PBC, and those are typically a thing called smooth muscle antibody. Sometimes we see the autoimmune hepatitis anti-nuclear antibody, but that's it. However, there are 2 other autoantibodies you get with autoimmune hepatitis. One of those is a thing called LKM, liver kidney microsomal antibody. And then the other one is a thing called soluble liver antigen, or SLA, which is what we're talking about here. Okay. Now, I have never seen anti-SLA in anybody with PBC. So it is not one of the autoantibodies I would expect to see in somebody with overlap between PBC and autoimmune hepatitis, because that's what we're talking about here. There are some people, not a large number, who have both autoimmune hepatitis and PBC, and the reason why that's important is because you need to treat the autoimmune hepatitis and the PBC in a different way. Okay, so is this a combination of autoimmune hepatitis and PBC? The PBC indicated by the AMA, the autoimmune hepatitis by SLA, and actually two conditions rather than overlap, because you just don't see SLA with overlap. The answer to that is I think it's extremely unlikely. And the reason for that is the blood tests are improving on URSO, which wouldn't happen for an SLA positive autoimmune hepatitis. So the immune activation of PBC gives you what I've said before. I think I talked about whack-a-mole, not guacamole, which is a food thing, but whack-a-mole, which is a kid's game. Can I tell you the Peter Mandelson story? No, I won't. The whack-a-mole is obviously where things pop up all the time, and we see a little bit of that. Remember I said at the beginning of this that you get activation, lots of antibodies in PBC when we were talking about rituximab. So basically your B cells are turned on. So sometimes you can chuck out all manner of different antibodies which are not relevant to it. So is this noise, or is this autoimmune hepatitis with PBC? So what I would do is I would look at the big picture with it. So the picture you've told me does not say autoimmune hepatitis in a million years, particularly not SLA, which can be quite aggressive, where you'd have a high ALT and it would not respond to the sorts of treatments that you've had. Okay. However, I have practiced medicine in my career by always filing things away and not forgetting them, and I think that's really helpful. So I would file this away and remember it, that SLA is unusual, and I would want to bear that in mind. So is there something grumbling along here which is just beyond PBC? I've said I've not seen it, but that doesn't mean it doesn't happen. We wouldn't frequently necessarily look for SLA. It isn't always done as part of a panel. So what would I do with that information? Well, I would keep a religious eye on my ALT and making sure it was normal at the end of my treatment, because it should be with PBC. And if it isn't, you need to be aware that there could be another process there. And then the other thing is, what other tests are there that can tell me whether there might be something else going on? And you're going to hate me for this. The definitive way of answering that is a liver biopsy. Okay. And I'm not advocating you have a liver biopsy, because if your blood tests are improving, that's the wrong thing to do. But what would be really useful here is FibroScan. So if your FibroScan ought to be really low, and 4 to 6 range, okay, given what you've said. If it's higher than that, it raises the possibility there's something else, and it falls with URSO as the biochemistry improves. So if it's higher than that, it sort of doesn't quite fit, and it raises the possibility there's something else going on there, in which case I think it probably is worth looking into it. But a falling ALT that goes back to normal, the normal FibroScan, I think I would watch this. This is just noise, but it is uncommon. SLA, it's a very different sort of autoimmune hepatitis, the one that associates with PBC. So it's one of those answers which is a 90-10 answer. 90% certainly don't worry about it all, but you don't forget the 10%, because you don't want somebody to come along later and say, oh, if only we'd thought about that. And so remember, in what we do, it's trends over time that really matter. Okay. So you get a lot of information from one set of tests, but heavens, you get information from those tests repeated, and it's the number of plots on a graph. So is your ALT normal 6 months into treatment? If not, why not? Is your FibroScan at the level you would expect it to be? If not, why not? You know, there is just a question mark against it. It's got an asterisk against it, let's say that.
Great, thank you. I'm just keeping an eye on time. Have you got a tight finish today?
No.
No, good. Right, next question that's on the list. Patient who's just had a hospital appointment where the doctor has stopped their URSO treatment because their ALP result is now within normal. My question is, I thought URSO was a lifelong treatment regardless of the ALP result. Yes, that's why I wanted to get to that one.
I guess you've not raised this one with Robert because you could have heard the explosion from where I live. Okay.
Yeah.
I'm going to pose everybody a question, right? I have high blood pressure. Here's one of my blood pressure tablets. Okay. My blood pressure is normal. Now, should I stop taking them? Right. Now, you're going to think, but that would be insane because your blood pressure will just go back up, right? So that's the level at which we're talking with this. This one, the reason why I was drumming my head and Mo was kind of putting her tin hat on is because this one crops up more frequently than you imagine it ought to. Shall we say that?
Yeah. And I think that's why I always like to bring it back as well.
I
Is
think
that
it's
just
always
in case,
worth
you
bringing
know.
it back. Every so often, this notion arises amongst clinicians and takes hold. It's the Japanese knotweed of ideas for doctors, and you just need to hack it back. Urso works because you take it, and as long as you take it, it dilutes out and reduces the number of toxic bile acid molecules that cause the injury. The moment you stop taking it, it just returns to how it was at the beginning, like my blood pressure would return to how it was at the beginning. And so you're absolutely right. Urso is a lifelong treatment, and it works for as long as you take it. It is not like an antibiotic that cures an infection. It is a long-term controlling treatment, like statin, like antihypertensives, like diabetes treatments, and so you continue taking it. Remember, if you can't tolerate Urso, and it does happen, it can cause people to be a bit sickly. Then there are nowadays alternative therapies. So one of the second line treatments that we use in people who haven't responded enough to Urso, they also all work in people who haven't taken Urso. You don't have to take Urso for those other drugs to work. So if you can't tolerate Urso, that is not a reason to not have treatment. There will always be an option that people take. Do you need to take Urso for the rest of your life? I think the answer to that is look at the picture, okay? And, you know, if you're 90 and you have mildly abnormal liver function tests, and it's a sort of PBC that's going to take 40 years to cause problems, then realistically, no. And so it's not insane for some people not to take Urso based on their own circumstances. And, we have this discussion with people, particularly if they're struggling to tolerate it. And there is an element of pragmatism about this. But for the vast majority of people under normal circumstances, Urso is safe, it's effective, it's well tolerated, it's cheap, and it should just become part of your daily routine. And do you know what? In terms of how it works, it's almost like a vitamin. I mean, it is something your body naturally produces like vitamins. It's just you don't have enough. And so it's just a supplement, really, is the way to think about it, rather than a complex drug. And I don't understand, I do not understand the logic sometimes of people who suggest that you stop it. So smile nicely and correct them. And there are a lot
help with that if needed.
Yeah, there's a lot of myths around all of this. The other myth, actually, while we're on it, is that one of the problems, I need to talk about rifampicin. One of the problems we get is availability of Urso at certain doses. And the reason for that is that a lot of it's made by generic companies, and they're a bit here today and gone tomorrow. And, a brand of Urso that you've taken, then you get a different one at the same dose, and it's a bit all over the place. And what this can do is to lead to stopping and starting of treatment, or you can't have that. You can't have that because those tablets aren't available. And then the other one is you've got people on 1,500 milligrams a day who are given 150 milligram tablets and are trying to stuff 10 tablets down, right? So you see a few of these things. The only branded Urso is Urso Folk, which is made by the Folk company. They invented this. They are huge supporters of research and care in PBC. And their drug is very predictable. You get exactly the same thing each time you get it. It's and if there are problems with it, you know where they are. You can phone them up, and they're very good. And the thing is that if you are struggling with taking the Urso, or you're struggling getting hold of the The easiest thing is simply to go onto Ursofolk in one of its doses. It's 250 and 500 milligram tablets, and take that, because it will be the same next month and next year and then the year after that, and it's very well understood. And of course, if you're on 1500 milligram today, what would you rather have? 3 500 milligram tablets, which are the same size as the 150s, or would you rather have 10 150s? Well, I don't want anybody to bother answering that question. It's obvious. Now, your GP will turn around and say, I can't possibly do that because it costs 10 times as much. Okay, 10 times as much. I've even had a GP say it costs 100 times as much. Do you think the health service is made of money? Actually, I can go into the NHS costing and find out exactly how much each of these drugs cost. And Ursofolk is exactly the same cost as generic Urso. It's 1p per pack less. Why? Because the generic manufacturers put their costs up to literally just under the patented medication, because the pharmacist is supposed to use generics when they're cheaper, and they're a penny cheaper. Now, I think that's a reasonable trade-off. So when your GP says it's 10 times as much, or I'm not allowed to do it, that is nonsense with a bow on. But for the pharmacist to dispense it, they have to prescribe the brand name. But it is perfectly correct to do that. So if your best interest is served by having Ursofolk at a dose of 500 milligrams, then that's what the GP should prescribe. And if they say they can't because it's too expensive, they're talking nonsense, because I've checked the figures.
Okay. I'm just going to take a couple of questions that we had in the chat earlier, so that we don't miss them as well. So we had someone from the 51st state has a little question for you.
Oh dear, I've upset them.
If your liver tests return to normal, can your liver still become cirrhotic?
Gosh, again, a very good question. There are people with cirrhosis whose liver function is normal, okay? And I've certainly seen those over the years, because fundamentally inflammation activity is different to progression and fibrosis. So blood tests are not everything, okay? And you just need to be aware of that, okay? And so therefore that caveat is always there. Clearly normal blood tests are better than abnormal blood tests, but that caveat is there. This is one of the reasons why FibroScan is so powerful, because that answers the one remaining niggly question: am I one of those people that has cirrhosis despite having normal liver function tests? Okay, so most of the FibroScanning we do is actually to reassure people. And the commonest indication we have for a FibroScan is somebody whose biochemistry returned to normal. What is their state of the liver? FibroScan comes back at 5, and I'll sit them down and say, this will never hurt you, okay? This will never hurt you. If you have abnormal blood tests and they return to normal with treatment, then it's very unusual for there to be an occult progression. I think this sometimes progresses silently. So strangely, in my experience, having an abnormal blood test that normalize is much lower risk. That's why the combination that's ideal is an ultrasound scan and a FibroScan and blood test. You don't need a FibroScan every month, or every 6 months or a year. Just a one-off baseline to work out where you're starting from. Okay, so the answer is almost certainly normal blood test equals normal, but normal blood test plus normal FibroScan absolutely indicates normal, and it allows us to be much clearer in the guidance we give. The thing I wanted to do about rifampicin, if you would give me some license, is that I would like the input of the community around rifampicin, because there has been an edict from NHS England that we are not allowed to prescribe rifampicin anymore, because it has to be restricted to people with TB, because there is a worldwide shortage of it. And without getting unduly political, there are a number of people coming into the country with TB now, right? So we've been told we are no longer allowed to prescribe rifampicin for itch in PBC. I have obviously completely ignored that, as you would expect, okay? Because it is not in the interest. My ethical obligation is to my patient in front of me. And if they're stable on rifampicin for control of the itch, that's my ethical duty discharged. And I do not owe an ethical duty to somebody I've never met with some other part of the country. Okay, I would like to know where if people are getting problems getting prescriptions for rifampicin dispensed, or you're getting problems from your doctor, because I've obviously told them to stuff it, their guidance. It was a requirement. Otherwise, there'll be serious consequences for me. Yeah, right. Come and have a go if you're hard enough. But let us know if that problem has arisen. I've been meaning to say this to you too. Now, one of the advantages of having an international medical advisory board, as we have in the PBC Foundation, of all our friends around the world with PBC, is I've asked all our friends around the world in the PBC community, the clinicians, is there a shortage of rifampicin? And the worldwide shortage of rifampicin only appears to be in the UK. So there isn't a worldwide shortage of rifampicin anywhere else. So please let us know about that, because that is not acceptable. It is unethical. And apparently we're required to prescribe an alternative therapy. So I did ask them, would they possibly let us know what the alternative therapy was for somebody stable on rifampicin, if that's okay. So just be live to that. I think it's political nonsense, but I will not jeopardize people's stability. And the one thing we know about rifampicin is if it works, stick with it. Don't fiddle, don't change, don't drop, don't do anything. Just keep taking it. It's one of these things that seems to be a little bit dependent on continuity. The other random thought, as if any of this isn't just random, the other question that's cropped up is about the effect of second-line therapy on symptoms. Okay. Which is a big live issue at the moment. So do elafibranor and seladelpar in particular improve fatigue and itch in PBC? And there is, I think, a danger that the companies over-egg what it does. I think there's some itch improvement, but, other improvements for people with symptoms I'm not so convinced about. However, and this is as unscientific as you can imagine, but I'm fairly convinced from what I've seen over the years that if people start those treatments before they've got symptoms, they never get symptoms. Okay. I'm just racking my brains about all the people I've seen. So I'm not so sure they're effective at removing symptoms, but I do wonder if they're useful at preventing symptoms. Okay. So I would be really interested in people's experience as to whether that is complete nonsense, which of course it may well be. So if there's anybody here who is on bezafibrate, obeticholic acid, seladelpar, elafibranor, fenofibrate, on those who didn't have symptoms and who developed symptoms after they started, so classical PBC symptoms of the type we talk about, I'd be interested to know, am I wrong? Because I think that's actually really important in the argument about how you use these treatments. And we're just interested in doing a crowdsourced study about that, actually, to find out about that. And I just want to know if I'm wrong, completely wrong about that. And I'm not sure. I don't think I am. I think these treatments are much more effective at preventing symptoms than they are at treating symptoms. Leave out obeticholic acid causing itch, because that's a different thing entirely. Does that make sense, Mo?
Yeah, no, it does. Yeah. What I think is I'll come to you. I might come to you offline and get a wee bit more detail, and we can maybe look at a socials post or something, so we get a wider reach. Yeah.
Because if that's right, it's an argument about using those therapies earlier in people. Okay. And what I said about rituximab, we were using it to treat fatigue, but it actually switched the disease off. Now these drugs switch the disease off, and if you switch the disease off before the disease has caused symptoms, then you maybe don't get symptoms.
Yeah.
Okay. So I've just been meaning to raise that. We maybe could chat about that at I was going to raise this at the patients conference. Just as I think
that would be great. That's a real opportunity for having lots of patients together in the room as well. So really,
I think it's an important question because people are now asking when you should use these drugs, who should you use them, what they're useful for. Everyone's going, oh, stop liver transplant. Blah, blah, blah. But the answer is we're very good at doing that already. And I don't think we understand necessarily the true value of these drugs. And I think the other question I would be interested in, and maybe, I think we're going to have to do a bit of an audience participation, aren't we? That I would be interested in whether people, particularly elafibranor and seladelpar as they come along, whether people would feel comfortable taking those drugs if the only goal was to stop developing symptoms in the future. Okay. And that's an important question, because maybe that's doing something that is too much for people. But knowing what we know about the symptoms, it's a really interesting question.
It is, yeah.
There you go.
I'll make some notes around this for the conference.
We've had some original thoughts today. It's unusual, isn't it?
Yeah. There's just one thing I want to touch on before we finish up.
I had too much coffee this morning, which is part of this.
You mentioned Q10 enzymes earlier, and there's just been a query about which that is. Am I right in saying it's coenzyme Q10?
Yes.
Yeah. So just to see if anyone was querying about that, we'll do that now.
Coenzyme Q10. It's used. We've done trials on it. It shows benefit for fatigue. There's a lot of work in the sports science literature on it. See previous comments about it. Improves the ability. It increases the ability of athletes to train, for example. So it's all, there's a logic behind it, and it's used by the cardiac people because it reduces angina in people with poor oxygen flow. Why? Because it makes them more efficient at using energy.
Thank you. That's been a brilliant session. Just to say, if we haven't got to your question today, if it's been sent in or it was in the chat, I do still have it. And we've got another session next week at 2 o'clock. I'll take it forward to that one. Just remember, when you're submitting your questions, you can do that either via the info mailbox or via the contact us on the website as well. And in the meantime, if you need us, you know that we're here for you. You just have to give us a call on the helpline.
And just as a follow-on to that is that we, as you know, we enjoy doing this, as you can tell and know, but we find these really interesting, informative discussions, and I think they are a source of original ideas. So if you've got a really good idea for something that we're all collectively not doing, I mean, I've literally never thought of, would a leaflet for physiotherapies about I've never thought about that, and yet it naturally came out of what we've talked about here. If there are other good ideas, bring them forward. And this is your forum, and these things are easily done, and it's just having that clever little thought. So do bring them forward.
We had a similar conversation with a patient who was asking about information for their employer, and we don't have a leaflet specifically for employers, but then we thought actually that's a really good idea as well. So we're working on that as well just now,
and reasonable adjustments. And I don't know if you're noticing this, but around the PIP changes and all of that, we've had more in the way of pushback of things. So I think that's a very good idea.
Yeah, well, actually, I'll be hosting a session, one of the breakout sessions at the patient conferences on asking for reasonable adjustments at work as well.
Yeah, and so those of you who aren't familiar with the term, reasonable adjustments is a legal requirement for employers to reasonably adjust your work pattern for those people with a disability. And disability, of course, is a broad term for chronic illness as well. So PBC as well, symptomatic PBC in particular, cirrhotic PBC or symptomatic PBC would fall within all of that. My experience of employers is that you have some really brilliant employers who cannot do enough, and they value their employees and they make the changes. They just don't know what to do, and you tell them and they make the changes, and happy employee, happy employer, happy everybody. And you have some really, really rubbish employers who are terrible at this, and I'm afraid it's the public sector that are terrible at this, in my experience.
I think putting together a leaflet where you can share with your employer, so it's easy to explain to them not just the condition but the symptoms that you manage, and then also we're going to put together some resources on what's acceptable to ask in terms of reasonable adjustments, just to give everyone a starting point. In all of that, what I think would be really useful is to give some examples of things that have been really effective. So in my experience, avoiding night shifts or late evenings. So for example, I don't need to tell anybody on this, in PBC fatigue, people are best in the morning and then they run out of power during the course of the day. That's very typical for PBC. But if you think about it, that's going to have impact on your working pattern. So actually early morning shifts tend to be fine for people, but anything into the evenings, and in particular overnight, is a real challenge. I don't know if she's on the call, but a patient I know very, very well indeed is cabin crew for Intercontinental Airline, and believe me, time zones, as a professional time zone crosser, I have utter admiration for how she copes with that, because it's anything that gets in the way of that normal pattern. So I think really simple, practical stuff. And they can also be small changes, can't they? Small changes can make such a big difference as well.
And the thing is, if you're a good employer and you value your employees, seeing the difference that makes is just good for everybody, isn't it? So
Absolutely,
as I say,
yeah.
it's not normally a fight. It's normally they just don't know.
Yeah.
And it's just a guidance thing, but some good examples of things that have made a difference like that. Maybe we should have a chat about that in the conference.
Yeah, because I know things like flexible working hours and things like that can make a massive difference as well.
Well, good days, good days and bad days. Being able to sit down, if you're going to run out of power and your knees, we've talked about your muscles running out of power. Well, if you're on your feet all day long, the ability to have a timeout is, very powerful. So it's stuff like that.
Brilliant. Thank you so much for that. I'm going to wrap up for today. I'll get this uploaded onto our YouTube channel as well late this afternoon. Thanks very much for your time, Professor Jones, and we'll look forward to the next time. Take care, guys. Bye.